Thanks, everyone, and good afternoon. It's really such a pleasure to be here, and I'm really indebted to Andy Goodman for pulling us all together. It's given me the chance to see many old friends, really comrades in arms, people who've worked at the health department, people who are working at the health department today, who I sadly don't get to see as often and as much as I'd like. So, in addition, we have people from all kinds of sectors. So this gathering really is showing us the multi-sector. So I'm delighted to be here and delighted to be with so many people who are joined in a commitment to public health. This is a time of really a lot of uncertainty. We have uncertain weather, which, although I'm so glad that so many of you made it out in spite of the snow, and it really is beautiful out there, but a lot of the uncertainty that we're facing is frightening, not in any way heartening. For somebody who has been committed to social justice for all of her working life, it is really a great source of dismay to be facing the sorts of challenges that we must all face. Now, they're going to include a lot of financial challenges to public health, and I know that I didn't get to hear Dr. Silver's talk this morning. She's promised me her slides, but the financial challenges to local health authorities are very real, to the public health enterprise are very real. The most immediate, of course, is the now more impending repeal of the Affordable Care Act. But I'm not going to talk about that today. I'm going to talk about what many of us consider a sort of squishier concept, and it is the importance of a real community engagement. And I want to make the case to you that this is just as important to protecting our public health project. I have been health commissioner now for 3 years, so it's time. I'm in my 4th year now. It's a 4-year administrative term, as you know. There'll be an election in November. So it's time that I, start looking back on what we've done. And I took a look at a message that I sent out to the health department shortly after I became commissioner. It was in part triggered by my experience as deputy commissioner, where I really got to work with people I consider truly giants in public health: Andy Goodman, Lynn Silver. Roger is in the room somewhere. Where's Roger? At the health at the health department, and there are probably others of you here too. But we got a lot of things really right during the Bloomberg administration. It was a great time for showing the power of government in picking up tools that only government can wield: regulation, legislation, taxation, to level the public playing field, so that people have an opportunity for healthier lives. But one thing that I was convinced that we had not succeeded in was the other pillar of public health, which is working with and alongside and with members of the communities that we most seek to serve. This, I believe, and I won't have time to stay too long for question and answers, was just one of the flaws that in the sugary beverage campaign, which led to a really quite severe curtailment of the power of our Board of Health, which has been so important to the pioneering status of the New York City Health Department. So anyway, I sent out this message, and I'm going to read to you what I said to the staff. And I said that chief among my goals and priorities was bettering our approach to community engagement and collaboration. This is the quote: "In the promotion of health, our most important tool is people, for whom health is a critical resource for everything in life, for work, for school, for play. And going forward, I will work hard to ensure that communities become our allies not least the people, organizations, and institutions in the communities that have an excess burden of ill health. So I want to talk with you today about some of the progress that we've made on that front and what I see as some of the important challenges, because I think it's important when we get together such a wonderful group of people like yourselves that we engage in some reflection. So we use these words: collaboration, partnership, collective impact. And they are surprisingly challenging practices for what seem like a pretty simple concept, which is when we work together, we can accomplish really great things. So I think it's worth reflecting on why it is so hard to implement community engagement. You know, we say other things that seem sort of simple. We all in this room would groan at the advice that we hear so often, that people should just eat better, get more physical activity, practice safe sex, go to the doctor, get enough sleep. These are all part of what has been thoroughly debunked as the myth of lifestyle choices, and it has prompted a whole wave of critical public health practitioners to question the structures of institutions, of our society that organize, incentivize, and normalize the conditions that lead to poor health. They are part of what we all have come to call health equity. So I wonder if topics like collaboration, community partnerships, community engagements wouldn't also benefit from a critical attitude. In addition to organizing convenings like this one, developing tools, models, frameworks, checklists, et cetera, to assist us and pushing us in the kind of conversations that were buzzing through the room when I walked in, to align our agendas and to figure out how we can get these things together to work. We should also be thinking about transforming the system that disincentivizes collaboration. In short, if healthy choice ought to be the easy choice, why shouldn't community partnerships or multi-sector collaborations be easy too? Now, this isn't to say at the health department that we've revolutionized our partnerships, at least not yet. And I know that there are in the room people who could give me a real talking to about how much further we have to go. But we're right here with you trying to figure out the best practices. And I want to share a little bit about what we've learned. And I thought I would start out by talking about our new community engagement framework. It will be publicly available soon as a document. And it is the product of where's Dr. Maybank? She's left already. A very long internal process that has involved review and sign off by a whole swath of people at the health department. You know, we have 13 different divisions at the health department. We're a staff of 6,000 people. So we've been looking hard at our practices. So this is called the Community Engagement Form. It'll be available on our website, and it's part a statement of principles, and it's part a guidance for practice. So its intention is to prime our agency to approach partnerships and engagement with a great deal more intentionality. We used a framework that was developed by the Department of Health and Human Services, so some of you may be familiar with their continuum of community engagement, that puts together a whole spectrum that progresses from outreach to consulting to involvement to collaboration to shared leadership. And to the Health and Human Services, at least the people who were there then, who drafted this document, these represented the stage of community engagement. So at the Health Department in New York City, we've taken this spectrum and really turned it into 4 distinct pathways. And these are forms of community engagement which may or may not lead to another form of community engagement. So, for example, you might decide that a media campaign would benefit from consulting a stakeholder group, but that it doesn't really have a need for shared leadership. Or you might decide that it does. And the point here is that the health department is going to be very careful and really take great care to think through exactly what it is we are doing, to consider its position and appropriately decide how to go outside the walls. Another thing that it does is establish across our agency a shared language. Our emergency preparedness people talked about community engagement. Our people who are working in the neighborhood health action centers talk about community engagement. And part of the role of this framework was to ensure that we all understood the words that we were using and we're moving towards a shared language. Because the truth about community engagement is a lot of it is incredibly ad hoc. It's sort of one of these generally agreed good things to do, but we don't do it in any orderly fashion. And so this doesn't always turn out to be a problem, but it does also create a whole narrative of missed opportunities. So we're aiming to give form and guidance to internal deliberations about our partnerships, and then our intention is that this hold us all more accountable. At the same time as creating this framework, it has a whole series of best practices, considerations, pros and cons, tactics, next steps. All of these are meant to guide staff and our partners at working together. So one of the things that I added to this report is about how to leverage our technical capacity. You know, you should know that New York City has a truly outstanding health department from a technical point of view. And I'm sometimes concerned that we sort of romanticize the participation of everyday people as a form of justice when we don't recognize at the same time what a tremendous burden people pick up when they decide to engage with their local health department. It's a burden, or with a community-based organization, or with a hospital system. So sometimes that burden is justified because we gain crucial insight from the lived experience of neighborhood residents, but other times I would argue that we have an institutional obligation to appropriately use our own training and skills, our own expertise, to make the best recommendations we have for improving community health. Now I'm coming to what I think is really the kernel of what I want to say to you about this, and that is that community engagement is most effective when it follows an analysis of power. In other words, we don't want to implore the community the burdensome and often uncompensated obligation of community input when it's not necessary to address an imbalance in power. So, for example, we believe that in righting the past injustices inflicted by health and public health institutions against women, particularly women of color, in the area of reproductive health, we needed to address the issue of power. And that's what led our Bureau of Maternal, Infant, and Reproductive Health to establish a sexual and reproductive justice community engagement group that brings together voices from advocates and activists across the city to better inform our programs, our campaigns, our investments, and our strategies. I don't know if we have anyone from MER here in the room. BMER is what some people call it, but I have to tell you, I've been working in public health for decades now, and you can get to the point where you think you've learned everything you have to learn, and your challenge is to try and do it. But I have learned so much from this whole process of working with the framework of sexual and reproductive justice about how we at the health department could improve our work. I'm a medical doctor by training. I can give you the example we had about long-acting contraceptives. LARC, I'm missing the acronym. reversible, right. And, you know, we know the data show that, particularly for young women, that these are much more effective. We would like women to use them if they don't want to be pregnant. I recommended LARC to my daughters when they became sexually active. But we learned a lot by talking about this message, about the ways in which imploring people or directing people to put something in their body that would alter their reproductive capacity resonated with a whole history of abuse that was part also of the legacy that we have to own in public health and in medicine. So this has been a tremendously enriching experience for our agency and has improved our work. On the other hand, we didn't need to turn to the community to find out that we were not getting calls for testing for Zika last year from the communities that we expected would be most affected by the Zika virus, from the communities in which many people had ties to the Caribbean and Latin America, where the Zika epidemic was raging. We could just look at our data ourselves and see that we were not successful in getting testing out to the communities that needed it. It needed us to be mindful of equity, but it didn't need the community to give us that. In fact, the community wouldn't even have been able to tell that testing was being distributed unequally across our city. So we were, because we've adopted an equity framework, able to identify this and correct it. And it's like looking through a flip chart. You know, first the neighborhoods of Washington Heights, the Bronx, Brooklyn, didn't have any tests coming. And over time, over a period of 3 or 4 months, we saw the pattern that we expected. So in some places, it's really important to leverage community engagement to right wrongs and balance the abuse or even potential abuse of institutional power. And in others, we just have to reform ourselves to use our power appropriately, our technical capacity appropriately. So it's because of that observation that I also want to talk a little bit about a broader effort that's going on in our department that is part of our goal of reshaping how we do community engagement. And that's our work to transform our agency into an anti-racist institution. We call this initiative Race to Justice, and it represents an all-hands-on-deck endeavor to reform the way we do business as a public health institution. We are undertaking trainings at all levels of the health department, internally, the senior leadership, all of the managerial staff, right on through all levels of our health department. So at the same time that we are talking about and advocating for really robustly, sometimes stridently, the need to address health disparities, our staff is organizing to carry out recommendations to transform our budgeting and contracting practices, our hiring procedures, our communications, and of course, our community engagement. The implication of this work for our partners is clear. We not only must work well with people and institutions outside of our walls, but we have to be a better organization to work with as well. And there is still a lot of work for us to do. So we see our commitment to racial justice and health equity not just as the right thing to do, but also as the right way to do public health. So I'll close by saying that we have a lot of work to do. We have a lot of work to do just maintaining this framework in our current political environment. But I hope that all of you will take the insights that you're getting from this meeting today, and I hope that you'll really feel recharged in spite of the weather, in spite of the uncertainty. And I ask that you consider how we can transform systems as we build partnerships, and that you bring intentionality to your work in community engagement. You consider the role that we all have to play in saying to ourselves, let's check the power. Let's check the imbalances in power and consider not just present, but historical. And last, I hope that you will all consider the role that this plays in advancing the charge of health equity. At best, collaboration shouldn't just be a defensive strategy, something that we've checked off on our list of things that we were asked to do, something that we view as a way of leveraging scarce resources, but a proactive strategy to assert lasting change. Thank you. So I was asked to leave about 10 minutes for questions, and I have time for a few questions before I have to charge out. So if there are any questions, I'd be most happy to address them. Wow. All right. I hope you realize that what I'm saying is quite radical. Okay. All right. Well, I think that, yes, Adrian.
I'm just wondering, with 4 years, with the close of the administration approaching, how do we institutionalize all of these radical changes? And are there things that we can be doing in our communities, more of this inflection, reflection, intentionality in our own communities to think about race and equity and building the capacity before this?
I think that's a really good question. It's obviously one that I ask myself a lot. So I'm going to answer it with an anecdote. We have something called a quarterly management meeting. Those of you who worked at the health department will remember them. We still have them. And we had one this week. And we had 3 different presentations on what the impact of this equity lens has been to our work. Now, you know the terrific Center for Health Equity, and we have some of the staff over at that end. Dr. Easterling, who's based in our office in Brooklyn. And many people might think that equity is just an issue that we handle over there. No. Equity is for our whole agency. So these presentations came from the Department of Public Health Engineering, the Department of Emergency Preparedness, and one that has escaped me just at the moment. But so, you know, we had a really interesting analysis from the Department of Emergency Preparedness and Response. It's actually called the Office of Emergency Preparedness and Response. That started out by seeing whether we could staff an emergency response, and ended up with a conversation about redlining in New York City. Now, this is amazing, because it turns out that we have hardly any people in managerial roles who live in the South Bronx, or in fact, in a big swath of the Bronx. So we would have trouble staffing, and that hadn't been realized until we took a look at it. Public health engineering does work around the safety of swimming pools. Now, a black child is many-fold times more likely to die in a swimming accident in a swimming pool than a white child, as are Latino children. So they've come up with a whole program to try and increase access to swimming. So, and they were so rigorous and passionate about their work. So I believe that the most important protection we have is by the fact that people, when they see how thinking in new ways has transformed their work, that they're on board with it. It becomes embedded in the health department. And it's not only about structures and trainings, but about people who have been convinced that the failure to address racism, the failure to address the enduring burden of poverty has damaged our ability to plan properly and execute our programming. So I have to believe that, because none of us is going to be around forever. And at the same time, of course, I think that all of us have a role to play in the coming time to continue to speak up and speak out. So I don't know, Adrian, if that answers your question completely, but I do want to say how rewarding it's been to have such a positive response from my department. When I joined the health department, there was not a single Black or Latino member of the senior team in New York City. You know, I mean, that's not good. That didn't reflect the ability and promise of our city's public health leadership. But it's not just about that. It's about who we are and what we do. And I've really seen the department embrace these concepts and really feel that their work's better because of it. So I mean that really quite sincerely. It's not just doing the right thing. It's doing public health in the right way. All right, so, oh no, now more people are raising their hands, and I have 3 minutes left.
As a follow-up kind of to that, I think it's kind of one thing to think about changing the institutions that we work in, but what about the non-believers? I mean, community health, I think, often does a good job of reinforcing and changing things to the converted, but I think the conversation last week with Ted Cruz really embodies a problem. We view and believe that health is a right, but a large percent of Americans view it healthcare access as a right, and those are two very different things, particularly considering that, you know, this is America, it's market driven, this is a business. So, you know, at what point do we engage, or if necessary, confront those who don't view equity as a priority, whether it's speaking their language or making campaigns to get them to I mean, where does that come into play?
Well, one thing that we can all point out is whatever we're doing, it's not working very well. I got, my sort of 5 minutes of fame during the Ebola response. And so I got invited to the business group. What's the name of that group? Huh? Really? I mean, Goldman Sachs CEOs were there, and okay. Okay, that's what it's called, partnership. So, so I pointed out to them that the United States gets the lowest grades on outcomes for chronic diseases, communicable diseases, everything, despite spending more by far than any other country on health. Our outcomes are terrible. They ought to worry about it. I'm worried about it, but they should worry too. So I think that I'm hopeful that we're about to see, you know, here in New York City, we think the repeal of the Affordable Care Act will cost 1.6 million people their health care insurance. Now, that's going to happen in other states. States that aren't blue states, that are red states. And the Affordable Care Act has lots of stuff in it. I mean, not just health care insurance. It has, calorie posting. It has covering screening tests. So it has a lot of stuff in it. And I don't think that people really want to lose that. So I think the facts are on our side. I don't think that it's easy to argue that what the market produces is what we all deserve. That is the fundamental argument of the right, that the market delivers to us what we all deserve to receive. But I think a lot of people will find that what they receive is inadequate, including people who are not from blue states or blue cities like New York. So I don't know if that answers your question, but the facts are certainly irrefutable. It's not just about, that we all are starry-eyed. There are such things as facts, real facts. I have to leave, I believe. Do I have one more?
Dr. Bassett, we talk about health equity and inequity in terms of the delivery of health system. Now, I represent a group of people in a section of Brooklyn that seem to be left out when it comes to although I represent here and I do partake in issues pertaining to the Department of Health, but when we think of the Center for Health Equity, which is for Brooklyn, but then the office is in Bed-Stuy, Troop Avenue, and when they look at their the area, the catchment area that they work in is Bed-Stuy, Bushwick, East New York, and Brownsville.
That's right.
And so, south of Eastern Parkway to, let's say, Coney Island Avenue, there is nothing.
That's right.
And is that because all the hospitals are located there? You feel that the hospitals are doing it for you?
No, no. I think when we established what were then known as district public health offices, we knew that only about a third of the people who have, that this frame only covered about a third of the population that had excess rates of poor health. So it's not perfect. But because of segregation, we have the ability to target by neighborhoods. There's some areas that we don't reach at all. In Queens, in Jamaica, in the northern rim of Staten Island, we don't have any presence on the ground in the form of neighborhood health action centers. So, you know, I agree with you, but I think that it's also a real start that we've acknowledged that we need to have an on-the-ground presence. And you may know that we are sort of reimagining these district health centers, these buildings that had gone empty for a long time or underutilized. We've invited in partners, community-based organizations, other agencies from city government to co-locate with the health department in these buildings. And I'm hopeful that we're going to see really great things come from them. Do we think we're doing enough? No, I would never argue that we're doing enough. Do we think we've got a good model to start with? I would say yes, and I think that it's really founded on the notion of community engagement in a way that is careful, rigorous, and to which we are very committed at the health department. So I want to thank you all for your time and